Hi, welcome back to my channel. Today I'm going to be discussing about lung tumors. And in this section, we're going to be talking about everything you need to know about lung tumors. And afterwards, we're going to take questions on this. Please like my channel, subscribe while we continue. So, carcinoma of the bronchus, the lung tumors. We're talking about the carcinoma of the bronchus. Epidemiology is said to be the second most common cancer in the United Kingdom. In the UK, 13% of all new cancer cases and 27% of cancer deaths, which is about 40,000 cases per year in the UK, increasing with incidence in women, and only 5% are cured. The risk factor for carcinoma of the bronchus is cigarette smoking, which make up to 90% of lung cancers, passive smoking, asbestosis or asbestos exposure, chromium, arsenic, iron oxide, radiation or gas, radon gas. The histology is divided into the small cell and the non-small cell. The small cell lung cancer make up 20%. 20% of it arise from the endocrine cells, which could be the Purkinje cells, often secrete polypeptide hormones like the ACTH or the Cushing's. Then 70% is disseminated at presentation. The non-small cell is divided into the squamous, which make up 35%, adenocarcinoma, the large cell, and adenocarcinoma in situ. The squamous make up the 35%, adenocarcinoma make up 27%, large cell make up 10%, adenocarcinoma in situ is rare and is less than 1%. Symptoms: cough is up to 80%. The majority of the symptom is cough, 80% of the time. Hemoptysis, 70%. Dyspnea, 60%. Chest pain, 40%. Recurrent or slow resolving pneumonia, lethargy, anorexia, weight loss. Signs you will see includes cachexia, anemia, clubbing, finger clubbing or toe clubbing. Then we have the hypertrophic pulmonary osteoarthropathy is also part of the sign. Then supraclavicular or axillary nodes. The chest sign include none or signs of consolidation. It could be either none or it could be signs of consolidation, signs of collapse or effusion. Then the complications from lung cancer include local or metastatic. The local ones are the recurrent laryngeal nerve palsy, the phrenic nerve palsy, the SVC obstruction, which is the superior vena cava obstruction, the ulnar syndrome or the Pancoast tumor, the rib erosion, the pericarditis or atrial fibrillation. The metastatic complications are brain metastasis to the brain, to the bone, which can come in form of pain, anemia, or increase in the calcium deposition. Then it could be metastasis to the liver or adrenals, which comes in form of Addison's. Then metastatic neurological could be confusion, fit or seizure, cerebellar syndrome, proximal myopathy, neuropathy. It could be polymyositis, Lambert-Eaton syndrome. The test to be done is Imaging. It could be imaging like chest x-ray, CT scan, PET scan, or CT. The chest x-ray, your findings could be peripheral nodules, hilar enlargement, consolidation, lung collapse, pleural effusion, bony secondaries. The findings on your CT scan could be tumor staging and biopsy guidance. The finding for the PET scan or CT or EBU scan, EBUS, could be staging or the metastasis assessment. Cytology could be sputum or pleural fluid, usually greater than 20 ml, greater than or equal to 20 ml of the pleural fluid will be useful. Biopsy could be fine needle aspiration, which could be in form of peripheral lesion or nodes. It could be bronchoscopy, which you can do the histology or operability assessment. It could be lung function test or assess suitability for lobectomy. You assess the suitability for lobectomy using the lung function test, or other lung tumors could be bronchial adenoma, which is rare, is slow growing, 90% are carcinoid tumors. Hematoma, which could be rare, is benign. Chest x-ray, when done, will show lobulated mass with flecks of calcification. Malignant mesothelioma could be tumor of mesothelial cells in pleura associated with asbestos exposure. Latency could be up to 45 years. Test and management. Mesothelioma tests could be chest x-ray or CT, pleural thickening or effusion, bloody pleural fluid. Diagnosis could be histology, in bracket the usually postmortem histology. Then the management could be pemetrexed plus cisplatin chemotherapy. Surgery could be rarely beneficial. Radiotherapy is also controversial. Pleurodesis, indwelling pleural drain. Prognosis is usually poor, especially without pemetrexed. It could be less than 2 years, greater than 650 deaths per year in the UK. Lung tumors, staging and treatment. Staging overview, purpose determines treatment course and prognosis. PET or CT is recommended for patients eligible for curative surgery. Some patients may require EBUS guided transbronchial needle aspiration for mediastinal masses. TNM staging classification for the non-small cell cancer, non-small cell lung cancer. TNM staging could be primary tumor. T standing for the tumor, N standing for the node, and M standing for the metastasis. The tumor TX means there is a malignant cell in bronchial secretion but no other tumor evidence. TIS means there is a tumor in situ. T0 means there is no evidence or non-evidence. T1 means the tumor is less than 3 cm in lobar or more distal airway. T2 means greater than 3 centimeter and greater than 2 centimeter distal to carina or any size with pleural involvement or obstruction. T3 involve chest wall, diaphragm, mediastinal pleura, pericardium, or less than or equal to 2 centimeter from carina. T4 involves mediastinum, heart, great vessels, trachea, esophagus, vertebral body, carina, malignant effusion, or nodules in another lobe. Regional node involvement, we have the N0 to N3. N0 means there is none involved, no nodes involved after the mediastinoscopy. N1 is peribronchial and or ipsilateral hilum. N2 is ipsilateral mediastinal or subcarina. N3 is collateral mediastinal or hilum, scalene or supraclavicular. Distal metastasis is M0 to M1. M0 is non-metastasis. M1 is as M1A and M1B. M1A is nodule in other lung, pleural effusion or malignant effusion. Then M1B is distal metastasis present. The staging occurs means there is no tumor evidence, no node evidence, and no metastasis evidence. Let's go back to what the TX mean. You can see, so non-evident, we are even wrong. T0 is the non-evident, while TX is malignant cells in bronchial secretion, no other tumor evidence. Somehow we are still correct, but in the bronchial secretion, there is a malignant cell in the bronchial secretion, but there is no other evidence elsewhere for the tumor. While N0 is non-involved, no node involvement after your mediastinoscopy, mediastinum now, mediastinoscopy. And M0 is non-metastasis. So stage 1, so the stages are usually stage 0 to stage 4. Stage 0 to stage 4. Then stage 1 is T1 or T2 N0 M0. T1 we know is tumor less than 3 cm in lobar or more distal airway. N0 is non-involved lymph node and M0 is no metastasis. Stage 2 is T1 or T2 N1 M0 or T3 N0 M0. So let's go over T1. T1, as we said, is tumor less than 3 cm in lobar or more distal airway. N0, no lymph node involvement. M0, no metastasis. T3, N1 is, because the first one says T1, T2, N1, M0. N1 is peribronchial and or ipsilateral hilum. Peribronchial or ipsilateral hilum. Then the T3 M0 N0. T3 is involves chest wall, the diaphragm, the mediastinal pleura, the pericardium, or less than 2 cm from the carina, and N0 no lymph node, M0 no metastasis. So let's go to the stage 2A, T3 N1 M0 or T1 to T3 N2M0. We already know T1, T3. Let's look at N2, which is ipsilateral, mediastinal, or subcarinal. So the T2 again is greater than 3 cm or greater than 2 cm distal to carina or any size with pleural involvement or obstruction. Then we have the 3B, which is T4N0 to N2M0 or T1 to T4 N3M0. We've already gone over the T4, right? Okay, T4 again involves the mediastinum, the heart, the great vessels, the trachea, the esophagus, the vertebral body, the carina, malignant effusion, or nodule in another lobe. And we've done the rest. Then the last one is stage 4, which is T1 to T4, N0 to N3, and M1, which shows that the tumor is big enough, the nodes are all involved, and there is a distant metastasis. Okay, so treatment. The non-small cell lung cancer, you could do surgery like lobectomy, which could be open, or thoracoscopic lobectomy is the treatment choice if curative. Then parenchyma sparing for smaller tumors, T1A to B, N0M0. Radical radiotherapy, stage 1 to 3, non-small cell lung cancer. Chemotherapy plus radiotherapy for more advanced disease. Small cell lung cancer, surgery with limited stage disease. Chemotherapy plus radiotherapy if well enough for the small cell lung cancer. All right, so palliative option could be radiotherapy for bronchial obstruction or superior vena cava obstruction. It could also be hemoptysis, bone pain, cerebral metastasis. Then superior vena cava stent plus radiotherapy plus dexamethasone. For superior vena cava obstruction, endobronchial therapy is useful. Tracheal stenting, cryotherapy, laser brachytherapy. Pleurodesis for symptomatic pleural effusion, pleural drainage. For symptomatic management, drugs like analgesic, steroid, antiemetic, cough, linctus, bronchodilator, antidepressant. Then prognosis. Non-small cell lung cancer has 50% 2-year survival without spread, 10% with spread. Small cell lung cancer, the median survival is 3 months if untreated, 1 to 1.5 years if treated, and prevention for general is to stop smoking and prevent occupational exposure to carcinogens. Thank you for watching up to this point. Please like my video, subscribe to my channel. Thank you so much.